What a frustrating histography. Zero cavity. Asherman syndrome, intrauterine synechia. The most challenging, most frustrating situation for gynecologists and for patients. The despair, loss of hope, amenorrhea, and complete obliteration of the uterine cavity. In this case, we will share together an innovative ideas, techniques, maneuvers to deal with such terrible situation. Well, Asherman surgery is a very sensitive because there is no anatomical landmark, the cavity is obliterated, there is no anatomy. So it depends on the tactile sensation and your ability to navigate and to drive through darkness. Well, number one, it's totally not accepted to use electrocautery in Asherman surgery. You should depend on mechanical instruments, only scissors. Plus, the most important aid to the surgeon here is the fluid push. As you see here, I'm gliding very slowly, millimeter by millimeter, giving a chance for the water pressure fluid to go before you. I mean, don't race with the water. Stand still, take your breath slowly, and give a chance for the jet of fluid to tear, to open the way, to disengage and release the adhesion. As you see here, this beautiful release of the adhesion, slow, soft, and simple. And I add more secret tips. Try to rotate your sheath to you direct the water jet towards the adhesion. Sometimes you are not sure if this is the adhesions to be dealt with. So if the water jet does not result in any release of tissues, change your direction like I'm doing now. It's millimeter rotation, exactly like the pilot rotating the aeroplane or by the wings, okay? So left and right, clockwise, anti-clockwise rotation, slowly. Give a chance for the water jet to open the way, and then you follow. In fact, the water pressure goes to the least resistance. As you see, it's a beautiful, enjoyable step. You appreciate the release. So this is not because of any pushing other than the fluid jet. And there's no fear at all from absorption of fluid in a case like this. When you find that the release of tissues stopped, this means that you reached the end point. So here I'm checking back my position. Every now and then pull back, recheck your position, try to identify a landmark. So my guessing is this side on your right hand side now could be the cornea. So again, gentle push is a combination of gentle push by the sheath and allowing the water to open the way in front of you. So I'm expecting to see something nice on this side, probably behind this curtain of white fibrous adhesions. There could be some evidence of a cornea. So again, observe the gradual release. Again, left and right movement to allow the jet of water to hit left and right, up and down. So it's all about manipulating the fluid pressure. And now, this is the enjoyable part. Here is a cornea. How can you identify the cornea? It's an ostium. It's because of the lining. The lining tissues is the endosalpinx. So now I'm trying to do the same step on the other side. I'm not sure if I can reach other cornea. When there is a release of tissues and the tactile feedback resistance is yielding, this means that you are going through adhesion. If you feel firm resistance, you are against the uterine wall. So any further push, you will see the bowels, okay? So it's all about the feedback tactile sensation when you push the telescope. Is it strong, tough, resistant? This means hard tissues, myometrium. If it is releasing slowly and tearing up, that this is the adhesion. So now, after this step, I want to clean the lens, and I am satisfied of creation of a good cavity exposure of the left cornea and ostium of the patient, but the right side is not still visual. This is the left cornea. Then I'm using the scissor, and here the scissor is used to palpate. The scissor should be extension of your hand. Palpate. I'm trying to probe different points until you get a clue that, yes, this is here, the other tubal ostium. The lining of the epithelium here tells you that this is the ostium and the endosalp. What an enjoyable moment when you reach exposure of both ostia, so you reach the maximum expansion left and right from side to side. Then you keep looking and estimate if there is much more expansion is needed. Sometimes I do overcorrection just for the sake if shrinkage of the cavity happen after that, there will be enough space and size. After complete satisfaction of expansion of the cavity, here I add a very nice step, which could be a future application to help regeneration of the endometrium. You can see a pinkish endometrium now. In the start, everything was red. So the coming step could be of value. It's still under research and evaluation, which is injection of PRP. PRP installation into the uterine cavity has been published long time ago, but my technique is different. It is subendometrial injection of platelet-rich plasma. Here I am using a long needle that can fit with the operative channel of the hysteroscope. It's a very long needle, which is used actually in the ovum pickup, oocyte retrieval for the IVF people. And you should thread it, push it exactly subendometrial. Please look carefully to the plane of injury. Don't go into the myometrium. Some authors starting now to apply the technique intramyometrial, but I do prefer to keep the fertilizer PRP subendometrial, so it will stay and it will work better than just installation into the uterine cavity. So please observe and appreciate the depth is exactly like subcutaneous, subcuticular plane. And you inject the PRP, and this case has actually had a post-operative hysterography. This is before, and you will see after. This is after surgery. She had a beautiful cavity. She received IVF, embryo transfer, and she got pregnant. Thank you very much. This is Osama Shawki from Cairo, Egypt.